Hello and welcome to the Pediatric Emergency Department. Today, as part of our lecture series for medical students rotating through the Pediatric Emergency Department, we're going to be talking about Croup. I'm Dr. Iman Lubani, one of the pediatric emergency physicians here at London Health Sciences Centre in London, Ontario, Canada, and I'm also the Pediatric Emergency Medicine Undergraduate Medical Education Director, as well as an assistant professor at Western University's Medical School. So what are our objectives today? We're going to define Croup today, review the epidemiology of Croup, understand the shift in epidemiology of Croup caused by the COVID-19 pandemic, review the clinical presentation of Croup, recognize the barky cough and stridor that are common presentations of Croup, and review the management of Croup. So what is Croup? Croup is a laryngotracheitis or laryngotracheobronchitis, an inflammation and narrowing of the trachea. It most commonly occurs in children 6 months to about 5 or 6 years old. It can occur in those younger or older, but that's less common. Most emergency department visits for Croup occur overnight. For some reason, the symptoms of Croup, the stridor, the barky cough, tend to be worse at night, and so parents often will bring their kids in then. Most commonly, Croup is caused by viral causes. What is the epidemiology of Croup? So historically, viral etiologies were the most common, with parainfluenza being the most common of those viral etiologies. Other causes were RSV, adenovirus, human coronavirus, and influenza. Interestingly, since the beginning of the COVID-19 pandemic, we've seen an increased incidence of Croup occurring secondary to SARS-CoV-2 or COVID-19 infection, and this has been strongly correlated with the Omicron variant. We've also been seeing, and this is what initial data is showing, that there's increased severity with the Omicron variant compared with other viral causes of Croup. But all of this needs to be studied further. How does Croup present clinically? Croup often presents with a preceding history of nasal congestion, runny nose, cough, and often the parents will describe the cough as barky or seal-like. The kid may then progress to developing stridor or respiratory distress. In some cases, children do have fever with Croup. Hypoxemia is an uncommon finding in Croup, and it's an ominous sign if it does occur in Croup. That means you may have impending respiratory failure, impending closure of the upper airway. But more often, the presence of hypoxemia means that you've actually made an incorrect diagnosis. It's not actually Croup. This is a clinical diagnosis, so imaging is rarely required. So identifying the barky cough and the stridor is not easy. We've got a video here of a little boy who does have stridor. What I will say before the video, I often, in order to elicit the stridor, I make the child cry. So I'll examine their ears or their throat, whatever it is that will upset them enough to cry. And this is because that will enhance the stridor. It'll make it easier for you to hear. So notice in this video that this child has an upper airway sound, so that is occurring on inspiration. We're going to take a listen now. So it's that intake of air that you're looking for, where you'll hear the stridor. What are some red flags? Things that when you find them in a patient with a diagnosis of Croup may make you sort of pause and think of other possible causes. If the child is less than 6 months old or greater than 6 years old, think of other possible causes of your stridor, not just Croup. So in a child less than 6 months old, consider congenital causes. In a child greater than 6 years old, think of other causes of other upper airway obstruction, such as foreign body aspiration or mediastinal mass. If you've got recurrent croup, again, consider other causes, things other than croup causing your upper airway obstruction in your stridor. If you've got hypoxemia or cyanosis, again, as I mentioned earlier, these are unusual findings in croup and often kind of end-stage findings in croup. So if you see them, think about what you may be missing. A toxic appearance or drooling should also prompt you to think of things like epiglottitis, bacterial tracheitis, or retropharyngeal abscess, things other than croup. Kids with croup don't usually appear toxic. An absent cough. Again, if you don't have a cough, think about what else might be causing this. Could this be a foreign body aspiration or some other cause of croup? Or, pardon me, some other cause of stridor. How do we manage croup? Steroids, in particular dexamethasone, have formed the mainstay of treatment in croup. They're shown to decrease ED length of stay, to decrease return visits to the emergency department, and to decrease the need for nebulized epinephrine. The dose is a little bit debatable, and there have been some Cochrane reviews looking at this that don't show a lot of difference, but anywhere from 0.15 milligrams per kilogram up to 0.6 milligrams per kilogram given in a single dose of dexamethasone. Higher doses may be superior in more severe croup, but there's not any clear evidence about that. Nebulized epinephrine is another treatment modality used in croup, and it's often reserved for more severe croup. So in our case in London Health Sciences Centre, we use it in children who have stridor at rest. It results in much more rapid clinical improvement than steroids. The clinical improvement occurs within minutes, up to 30 minutes post-administration of the nebulized epi, but it only lasts about an hour and a half to 2 hours, where the steroids start to act in about 4 hours, but will last up to 72 hours. So when we give nebulized epinephrine, we will often keep these children in the emergency department and observe them for a minimum of that 2 hours to make sure that they don't have a return of their symptoms once the nebulized epinephrine has worn off. Humidified air has not been shown to have any benefit in croup, and Heliox has not been shown to have any. So after that short presentation, let's take a look at a couple of questions to test our knowledge about croup. All of the following are true about croup except croup is the result of inflammation and narrowing of the trachea, the upper airway. Croup is most commonly caused by bacterial infections. The epidemiology of croup has shifted since the start of the COVID-19 pandemic, and croup affects children aged 6 months to 5 or 6 years old. So the false statement here is B. Croup is not commonly caused by bacterial infections. It's most commonly caused by viral infections. Question 2. Proven treatments for croup include A. Dexamethasone, B. Nebulized epinephrine, C. Antibiotics, and D. Both A and B. The answer here is D. Dexamethasone and nebulized epinephrine are proven treatments for croup. Antibiotics are not. These are mostly viral infections, so we do not use antibiotics in treatment. So that brings us to the end of this lecture. Make sure to check out the other lectures available on our website. Best of luck to you guys, and see you in the emergency department.